My name is Cyrus Jordan. I'm the director of the Vermont Medical Society Education and Research Foundation. I'm the principal investigator for this project. The project's funded by the Vermont Healthcare Innovation Project and the Physicians Foundation. Project team, there are 9 of us with diverse backgrounds. I'd just like to point out that 3 of the research teams are actually primary care physicians that worked in the 2 primary care service areas that we're focusing on in this project. This project actually started in April of 2013 when the then chair of the Green Mountain Care Board, Anya Rader-Wallach, reached out to the foundation to try to get input from direct care providers into how we should think about healthcare reform in the state. And she realized that unless we really change the delivery system and unless we really involve the direct care providers and the patients, that all our efforts at cost control would be fleeting, as she mentions in her quote. So the Green Mountain Care Board contracted with the Vermont Medical Society Foundation in 2013 to make recommendations of what some of the key or core community services were and where there were mismatches, where there were needs across our state. And that white paper, which you can find on another part of the foundation's website, made 3 recommendations that, given our stable population, we could really plan 3 levels of care based on the population's need. We wanted to be a magnet for the healthcare workforce. We have an older workforce, a lot of pressure, particularly in primary care, a lot of specialties in the rural communities. We want to become a magnet for the workforce. We want to become a benchmark for measurement. There's a lot of measurement. It's an enormous burden right now, particularly in primary care, and it's not particularly useful, and so we want to propose new measures. And we also wanted to decrease the gap between practice and policy. And as Dr. Wallach realized, unless the people that actually deliver the care and the patients that receive the care's voices are heard, the policy decisions can spin away from what really matters. We broadened the input during the course of the next several months. Brought in people from all over the state. The initial effort was really concentrated in the 2 primary care service areas that the research will focus on. We actually, of interest, in April 3rd of 2014, 2 primary care providers, Dr. Faye Holman and Marlene Bristol, made a presentation to the Green Mountain Care Board about their idealized view of what primary care would be. And of interest to you that are looking at the website, there's another video on the site where you can actually listen to Faye and Marlene's view today in 2016. It's very consistent with their view that we proposed back in 2 years ago. We finally got funding. The project went through a lot of controversy publicly, and that the public debate really improved the project. It expanded the project. Initially, we were really just looking at a really practice-centric, primary care practice-centric project, but the public debate broaden the project and broaden the input to include all community-based support services, not just the traditional medical services. So the title of the project is the Frail Elders Project, and as we research team met, we started talking to people, we realized that we wanted to target a broader population. So you can see in our target population, it's really all seniors at risk of a decline in their quality of lives or a poor health outcome. The aim of the project, as we mentioned before, we're taking a deep dive into 2 primary care service areas, the Gifford Healthcare area and Little Rivers primary care service areas in central Vermont. And the deliverables to the Vermont Health Innovation Project were some recommendations about practice changes to primary care, to the way community-based care and supportive services were delivered. So it would improve things that matter to patients, payment innovations to support these redesigns, and then measures that would track changes in the outcomes that matter to patients. So one of the first things the research team did is come up with our research focus areas or research questions. And these 10 questions really directed our research. These are the questions that we posed to our various sources of information. These are the findings we wanted to have to serve as a basis for our recommendations for practice and changes to community support services, measures, and payment innovation. As I mentioned before, this is a small scale but a broad scope project. We're taking a deep dive into 2 primary care service areas in rural central Vermont. Not all the sources lent themselves to our research questions, but they overall guided our research and our findings. So we directed our 10 research questions at 5 different sources. We call them research arms. One was structured interviews and focus groups with seniors in these 2 communities and their caregivers. We made sure to include homebound people. Their needs are different than people that could had the resources to make it to the focus groups. We did a extensive literature search with the help of UVM Dana Medical Library. We interviewed 33 direct care providers in these communities. This was included primary care, clinical people in the clinics, people that worked for Area Agency on Aging, Meals on Wheels, clergy, EMT professionals. It was a very broad definition of providers. We interviewed 5 subject matter experts and policy experts here in the state, and we have also done and continue to do analysis of some survey data with the Vermont Household Insurance Survey and the Federal Current Medicare Beneficiaries Survey. So the findings from these research arms are probably the most important part of this project. And they are well captured in some very well-written reports. One report, there you can see there on the drop-down menu of the website, was based on both the interviews with seniors themselves and their caregivers and a literature search on what actually matters to at-risk seniors. There's another report on who are the frail high-risk seniors in our communities and what kind of models are people using elsewhere to care for this special population. There's an interview study that compresses both the provider and the policy interviews. We did that because there essentially was no difference in what the providers or the policy people were saying. And then finally, we have the final report and recommendations. And the final report summarizes the findings and then also offers our recommendations on practice changes, community changes, measures, and payment innovation. This slide I want to actually spend some time on, because I mentioned before the findings are probably the most important and hopefully lasting part of the research. As I mentioned before, there was essentially no difference in what we heard, whether we were talking to seniors, reviewing the literature, talking to policy experts, talking to direct care providers. And I would like just to read through these findings, because each one's really important. There are definitely mismatches between what gets paid for now and what's important to seniors. Today's payment policies create significant inefficiencies and actually harm Vermont seniors. Personal finances matter, and many seniors get caught in the middle between eligibility for public support and sufficient personal resources. Physical health matters to seniors, but remaining at home, retaining autonomy, not feeling like a burden matter at least as much. Care should go to patients. Patients shouldn't have to come to care. We heard this from everybody we interviewed, and it's really supported in the literature search. Control over the healthcare budgets and how we spend our money means much more community level influence, less management from the top. Primary care is a critical condition, and we all need how to rethink how to support it. There are proven examples of how we could do this to better, and there's a lot that can be done right now without moving major mountains. The recommendations based on the findings are organized by these 4 questions. Who are high-risk seniors? How will we measure success? How we care for them, and how we pay for that care? I just want to bring everyone's attention to the fact that we purposely defined how we were going to measure success in terms of what matters to patients before we started thinking about how we were going to care for them, and certainly before how we were going to pay for them. The central focus of this whole project is what matters to seniors, how do you measure that, how do you deliver care so it moves the needle on those measures, and then finally, how do we pay for it? So the first question, who are high-risk seniors? And the related question, how are we going to identify them? Again, the findings were consistent across all research arms that on who were the high-risk seniors, and just like to call attention to the fact that social determinants were probably the most frequently cited risk factor. How are we going to identify them? When we started, as I mentioned, we had 3 primary care physicians from these 2 communities on the project team, and we all just assumed we were going to do universal screening. But actually, when we talked to people in the communities, we realized that was probably not sustainable, difficult to implement, and the literature actually supported that. So what we are recommending is a 3-step identification project, which we'll go into detail in the recommendations. Second question, how will we measure success? Our recommendation is that we use a multidimensional balanced evaluation. There's no single index of success. There are validated metrics that exist. We make recommendations on the scope of the measures, and then also about using appropriate benchmarks to measure success. I want to mention and stress this again, that measures really matter. And we purposely put this question second before we make recommendations, even thought about our care models or how we're going to pay for it, because measures matter. So for instance, if we choose avoiding hospitalization versus something that really matters to a senior, which is making it to their granddaughter's wedding, it might lead to very different care models. That senior might actually want to, if they understood that a brief hospitalization might help them make it to their granddaughter's wedding, and making to the wedding is what really mattered. It leads to a very different model than if the measure was just decreased hospitalizations. The intent of the care model is best captured in the following video.
There are a lot of factors that are kind of working against us of giving the kind of care that we'd like to give to our seniors. Oftentimes the seniors have problems that need to be addressed either at home because it's hard for them to get here, or have to be addressed very quickly because it's of urgency either medically or emotionally to them. And the way healthcare works right now is very hard to respond quickly, get people in on short notice, get someone out to their home is difficult. And care gets fragmented, and we've been thinking about ways to do better with that. Well, in the early part of this study, we did some focus groups with seniors to ask them about what was important to them. And it isn't really the way our system is built. Many of them talked, for instance, about transportation. It's really difficult for them to get to the places they want to be. And some of them talked about just help with basic things at home, shoveling the walk, raking the leaves, that sort of thing. We certainly don't have a healthcare system that takes those needs into account. And certainly the way healthcare is paid for doesn't allow for those things to be taken into account. But if we could develop a system that really linked healthcare with the community supports, I think it would really allow people to maintain their independence at home. And if there's one thing that came out of those patient interviews early, it was that staying independent, not being a burden to others, is what's really most important to the seniors in our community.
If we've been following a person for their care for several years, we know their diagnosis, we know the meds they're on, we know how they function from day to day. We may even have an idea of what their needs are as far as food or finances in their home. When an elderly person or any person goes into an emergency room, quite often they're going to get a full workup that's extremely pricey and many times not completely necessary. If this patient is one of our patients, we will have a better idea of exactly what their needs are.
It feels like we know things that we could be doing for our seniors and we're not doing them. And maybe it's just looking for as excellent healthcare that we can deliver. It seems that it almost automatically brings in these the community issues, the family support, the home support, making sure the caregivers are on the same page as the doctors and the nurses. I think we see an awful lot of waste, both in terms of financial waste when patients end up hospitalized who don't need to, but also just taxing on the patient themselves and on their families when care isn't as comprehensive as it can be. One of my patients recently, who's doing quite well and in her 90s and living alone, she said, I just wish there was somebody who could come and have a cup of tea with me. And that's the kind of thing I think that made us start looking into this project about what we could do. So, a request as simple as that really can help somebody's health when they're a frail elder.
In primary care, there's really no going home and feeling like you're finished with your job. It's always with you. There's always someone I'm thinking about. When I've been taking care of somebody for so many years, I've invested, I hate to say it, emotionally in this person. And I don't want to let it go to some other organization and not follow them through. There's a trust that's developed between the primary care provider and the patient over time. And that is a privilege on my part to be so intimately involved in someone's lives and in their family's lives.
So as mentioned before, we left this question to last because we thought it was the least important of the 4 questions. We kept coming back to what matters to seniors. How do we measure that? How do we create a care model that supports that, those things that matter to seniors? And then finally, how would we pay for that care model? Elements of the care model exist elsewhere. They're currently being paid for. The report goes into cites some examples, and then also gives some broad recommendations. One of the things that we heard a lot about, and the listener should be aware of, the reader of the recommendation should be aware of, is there are a lot of seniors in our communities that get caught in the middle, as was commonly said, where their financial situation is not so dire that they are eligible for public support, but their personal resources are insufficient to make their needs. And that's just one of the things that the listener and the reader of the recommendations keeps in mind, because some of the models that are out there, some of the most successful models are more restrictive, and their eligibility is limited to most financially disadvantaged or most medically in need. And this video ends with a slide you've already seen with the findings, and purposely because we want to emphasize that this may be the most important part of the project, is the findings. And all else should be based on that. Our recommendations are unavoidably subjective. We think we analyze the findings, we reach these by a consensus process, and people may come up with different ideas about care models or measurement or payment innovation. But what we hope is lasting and we hope policy doesn't spin away from is what matters to seniors.